السلام عليكم. عيد مبارك. كل عام وانتم بخير. Today we have three lecture starting with the resuscitation after cardiac surgery guideline presented by Dr. Hani Barnawi. Second lecture, pathophysiology and diagnosis of infective endocarditis presented by Dr. Muhammad Al-Mutlaq, and finally conduit choices in infective endocarditis by Dr. Firas. Dr. Hani, we can start. Dr. Hani.
Hey, السلام عليكم. Can you hear me?
Yes, clear.
تمام دحين. Assalamu alaikum. My name is Hani Barnawi and I'm R2 in King Faisal Specialist Hospital, Jeddah. My topic for today is post-cardiac surgery resuscitation guideline. I'm gonna start with that. So a quick review, cardiac arrest occurs after 0.7 to 8% of cardiac surgery cases. Usually it is preceded by physiological deterioration that can occur in a previously stable patients. The most remarkable statistic regarding these patients is their relatively good outcome, owing that to reversible causes. The survival is around 80%, and the reason, as I said, is due to the high incidence of reversible causes. Often, distinct causes are present, such as tamponade, hypovolemia, myocardial ischemia, tension pneumothorax, or pacing failure. Emergency resternotomy should form a standard part of the arrest protocol up to the 10th post-op day. So the goals of identifying the cardiac arrest post-cardiac surgery as early as possible is to provide the definitive therapy quickly, either open chest or defibrillate. Timely resternotomy is an important goal, as CPR is ineffective if tamponade or hemorrhage is the cause. And of course, call a surgical emergency. So we're going to start by identification. An absence of pulsatile arterial line with flat saturation, central venous and pulmonary artery pressure traces, and reduction in the end-tidal carbon dioxide all signify a cardiac arrest and invite the first responder to activate the cardiac surgery advanced life support protocol. In contrast with conventional resuscitation, and owing to a potentially fatal complication of graft failure, injury, cardiac injury, the external compression can be delayed for up to 1 minute following identification of either VF or pulseless VTAC to allow for expeditious defibrillation and also to allow for institution of pacing in asystole or severe bradycardia. Pulseless electrical activity arrest should receive immediate compression or compression, yes, in line with the conventional published. In the cardiac surgical patient, the efficacy of defibrillation reduces by 10% for every minute delay. In addition, success rates of for immediate sequential shocks start from the first one up to 78%, and it goes down up to 13% after the third shock. Therefore, immediate defibrillation with 3 sequential attempts at 150 joules is advised. Immediate resternotomy is advised. Therefore, this should be anticipated and prepared for during the above attempts. During the early resternotomy, a bolus of 300 milligram of amiodarone should be administered with a further dose of 150 in refractory cases. Lidocaine can be also used instead of the amiodarone, giving the same effect. The initial arrest rhythm will respond to defibrillation in up to 50%, and many patients arrest with a non-shockable rhythm resulting from tamponade, tension pneumothorax, or severe hypovolemia. If immediate pacing fails to resolve an asystolic arrest, or if the presenting rhythm is pulseless electrical activity, then immediate external compression should commence. The effectiveness of the external cardiac compression is confirmed by monitoring the arterial pressure trace with a target compression of heart rate from 100 to 120 and the depth to achieve a systolic of more than 16 millimeter mercury. To maintain a mean perfusion pressure and to an inability to achieve a systolic of 60%, either the technique should be revised or inadequate preload secondary to persistent hypovolemia, cardiac tamponade, tension pneumothorax, or tension pneumothorax. Emergency resternotomy will help to address these problems. So the guideline states that once cardiac arrest been identified, an algorithm should be started. After assessing the rhythm, there are 3 cases, either ventricular tachycardia or VFib. You're going to start by DC shock, 3 attempts, and then start if the pulse was not regained, then basic life support should be started. Amiodarone 300 should be given via central venous line. And if still pulse was not achieved, prepare for emergency resternotomy. If asystole or severe bradycardia, if the pacer is available, then pacing should start. If it didn't help, then basic life support should start And if there was not a pacer wire, then consider external pacing. And meantime, prepare also for emergency resternotomy. For pulseless electrical activity, they should start promptly the basic life support. If it was paced, then turn off the pacing to exclude the underlying VFib. Meanwhile, also prepare for emergency resternotomy. So after identification, there are 6 rules in the during this period. Each rule has its own part. The first rule is the external cardiac massage. Once the cardiac arrest has been established, one person is allocated for external cardiac compression that should begin at a rate of 100 to 120. The only exception is if there was an underlying shockable rhythm. For the airway and breathing, the second rescuer increases the inspired oxygen to 100% and removes the positive and expiratory pressure just to decrease the intrathoracic pressure to increase the volume, the venous return, and to assist the airway and breathing per protocol, especially to exclude the pneumothorax, hemothorax. Or he also checked the endotracheal tube for any problems. For the defibrillation, the defibrillator should be connected and shocks administered if required. Also, this person should check the pacing, and if the emergency resternotomy is being performed, he should ensure that the internal defibrillator are available and connected. For the team leader, this usually is the senior person who should conduct the overall management of the cardiac arrest, ensuring that the protocol is followed and a person is allocated. In addition, the senior person ensures that the team quickly prepares for resternotomy. Drug administration, this person stops all the infusion after the initial resuscitative efforts have failed and administers amiodarone, as we said, 300, and manages other drugs or infusion as appropriate. Epinephrine or vasopressin. The guidelines state that up to date, no placebo-controlled trials have shown that administration of any pressors agent at vasopressor agent at any stage during the management of VF, pulseless VT, pulseless electrical activity, or asystole increases the rate of neurologically intact survival to hospital discharge. Neither the epinephrine nor vasopressin should be given during the cardiac arrest unless it was ordered by a senior clinician in their use. The amiodarone or lidocaine, evidence was sought as to whether amiodarone or lidocaine may be useful for the VF, pulseless or VTAC, not responding to defibrillation. And it says that it should be given after 3 failed attempts at defibrillation. As we said, a bolus of 300 milligram IV should be given, and the lidocaine can have a similar effect, 1 milligram per kg. Atropine, the benefit of atropine is not well established, and for patients with the asystole or extreme bradycardia, atropine is not recommended as a routine use. The sixth role is the ICU coordinator. The role of this person, typically a charge nurse or a senior nursing unit leader, is to coordinate activity peripheral to the bedside. That includes preparing for potential resternotomy as soon as the cardiac arrest is called, directing available personnel and calling for expert assistance if not immediately available, while continually reporting progress to the team leader. As we can see in the picture, there is the sternotomy trolley. We're going to talk about it later on. For the resternotomy team, in addition to the 6 key role above, a resternotomy team should be identified and immediately gown and glove in preparation for emergency resternotomy. That should occur immediately upon identifying a cardiac arrest rather than waiting until other conservative attempts at resuscitation have failed. Because arrest due to tamponade is always possible, this team must be sufficiently trained to always be able to perform a resternotomy within 5 minutes of arrest in the ICU. Emergency resternotomy after non-VF, non-VTAC arrest. In non-cardiac surgical patients, a non-VF or VTAC arrest are associated with poor outcomes. The American Heart Association guidelines ask the clinician to consider the following or to rule out the following H&Ts, which are the causes of cardiac arrest: hypoxia, hypovolemia, hypokalemia, hyperkalemia, hypothermia, hydrogen ions or acidosis, tension pneumothorax, thromboembolism, tamponade, and toxins. In contrast, cardiac surgical patients who have a non-VF or VTAC arrest are likely to have tamponade, severe hypovolemia, or tension pneumothorax. Prompt treatment is associated with an excellent outcome, and an impact of delays to perform resternotomy should therefore not be minimized. As we said, the H&Ds should be considered. In turn, it is apparent that none of these should delay the resternotomy. In a non-VF or VTAC cardiac arrest that does not resolve after pacing and exclusion of readily reversible causes, emergency resternotomy should be performed within 5 minutes. Open versus closed chest cardiac massage or compression. Closed chest massage generates a cardiac index of around 0.6 liter per minute per cubic meter, which raises up to 1.3 with an open chest massage. An internal cardiac massage is superior to external cardiac massage in patients with recent resternotomy, in whom resuscitative efforts are likely to last more than 5 minutes. Emergency resternotomy is indicated to perform internal cardiac massage. They report the benefit of internal cardiac massage that include better coronary perfusion, increased return of spontaneous circulation, superior organ blood flow, and better survival rates as compared with the external cardiac massage. There are risks associated with resternotomy and internal cardiac massage, including cardiac injury, graft injury, that could be reduced with the appropriate technique. The risk of harm from external cardiac massage post-cardiac surgery is difficult to quantify and is likely low. However, there have been a few case reports of significant cardiac injury. For the emergency resternotomy set, a small emergency resternotomy set should be available in every ICU, containing only the instrument necessary to perform the resternotomy, which are the spreader, wire cutter, heavy needle holder, and a single piece of scalpel and sucker. All in one drape and scissor is also useful. For the resternotomy procedure, it should be done under sterile technique if possible. Adhesive dressing should be available. Scalpel through the dressing to wires the skin. And one person cuts the wires while the other will hold the wires with a heavy needle holder. Suction should be done. Spreader should be after that. Spreader should be applied, and remove any clot if you identify it, and identify the position of the grafts, if any. As we said, the internal cardiac massage. Before attempting internal massage, inspect the heart to locate the internal memory if it was used, and other grafts carefully. Carefully remove the blood clots. You should pass the right hand over the apex of the heart, thus minimizing the likelihood of avulging the grafts, as these are rarely placed near the apex. And with the right hand also is then further advanced around the apex to the back of the heart with the palm up and hand flat. The left hand is then placed flat onto the anterior surface of the heart, and to and the two hands are squeezed together. The flat palm and straight fingers are important to avoid unequal distribution of pressure into the heart and thereby minimizing the chance of trauma. If there is a mitral valve replacement or repair, care should be taken not to lift the apex by the right hand, as this can cause the posterior ventricular rupture. A cardiac arrest protocol and emergency resternotomy outside the ICU. In a mixed ward areas outside the cardiac surgery ICU, it may not be appropriate to follow these guidelines. Hence, immediate defibrillation or pacing and epinephrine dose should be given as in AHA guidelines. How long after cardiac surgery emergency resternotomy no longer indicated? It is the opinion of the task force that significant adhesions would be unlikely to be present until the least 10 days post-op. Therefore, emergency resternotomy should form a standard part of the cardiac arrest protocol until the 10th post-operative day. Emergency resternotomy should form an integral part of the cardiac arrest protocol, as we said, until the 10th post-op day. Beyond the 10th post-op day, senior clinicians should decide whether emergency resternotomy should still be performed or not. Cardiopulmonary bypass after emergency resternotomy. If spontaneous cardiac output has not been established after emergency resternotomy and internal cardiac massage, a further option is the institution of cardiopulmonary bypass. There are no papers to guide the technical aspect and the safe passage into the bypass in this special situation. Yet one study documented a 56% survival among 16 patients with refractory VFib, despite open chest cardiopulmonary resuscitation, who were then placed on bypass in the ICU. In addition to an immediate dose to the patient of 30,000 units of heparin as early as possible, and commencement of cardiopulmonary bypass, the guideline recommend that additional 10,000 units of heparin should be added to the bypass machine reservoir. Of course, we in this scenario, we're talking about the ECMO. Should patients after emergency resternotomy receive additional antibiotic? It is a common practice to perform an antiseptic washout after an emergency resternotomy. Yet that is adding or receiving an additional antibiotic is reasonable and is indicated, especially if the resternotomy has not been performed using full aseptic technique. Induction of hypothermia after resuscitation from prolonged cardiac arrest. The current guidelines recommend that comatose adult patients with return of spontaneous circulation after arrest have targeted temperature management. The temperature should be from 32 to 36 during the targeted temperature management. During that time, at least the targeted temperature management should be maintained at least for 24 hours after achieving. There are a few special considerations with these guidelines. The transplant patients undergoing heart, lung, or double lung transplant through a sternotomy may be resuscitated using this guideline with an emergency sternotomy. Patients having a transplant procedure through a clamshell incision or bilateral thoracotomy incision may have an emergency reopening of the clamshell incision using the same indication in this guideline. Patients with bilateral thoracotomy may need a sternotomy in case of an arrest. Only a surgeon experienced in this particular approach should perform this procedure. Regarding pediatric patients, the incidence of cardiac arrest in pediatric is around 4% after a cardiac surgery. The success of resuscitation is similar to that of an adult, and the causes are similar, although 11% had a respiratory arrest. Pediatric cardiac surgery ICUs may use this protocol. The only thing is they have to adjust the medication, the doses of the medications to fit the pediatric. Open chest patients, occasionally after a high-risk operation, a patient will be returned to the cardiac surgery ICU with the sternum open. The heart may be surrounded by gauze packs, especially if bleeding has been difficult to control. Such patients are at a higher risk for cardiac arrest. Thus, external cardiac massage should be performed at the midpoint of the chest over the packs, and the arterial pressure trace would be observed to assess the effectiveness of the external massage. If emergency internal cardiac massage is then indicated, full aseptic technique should be used, and that will be easier as sternal wires will not need to be removed. In particular, the packs may contribute to cardiac compression in inducing an element of tamponade and should be carefully removed, making sure that no grafts are adhered to them. Patients with cardiac assist devices, external cardiac massage may be particularly useful to decompress a non-functional right ventricle in cardiac arrest, and often the right ventricle may be the cause of the situation. The rhythm should be certain. Patients with VF should be defibrillated. Asystole should receive a pacing, and in patients with pulseless electrical activity, it should be verified that there is no underlying VF. Massage should be performed if immediate resuscitative efforts failed. Importantly, the airway and breathing checks should always be performed as described earlier. For patients undergoing non-sternotomy cardiac surgery, surgeons who perform non-sternotomy surgery should make their ICU staff aware of their preferences for management during the cardiac arrest, preferably by means of a written protocol. Options include sternotomy in the ICU, sternotomy in an operating room, or ECMO. Preparation should be made for these eventualities. Patients who arrest after minimally invasive coronary artery bypass surgery, totally endoscopic coronary artery bypass surgery, robotic endoscopic coronary artery bypass graft surgery, port access mitral surgery, mini sternotomy, mini thoracotomy, aortic valve surgery, should undergo a full sternotomy after following our protocol, but only by experienced clinician trained in sternotomy. Of course, an acceptable alternative is ECMO. Cardiac arrest in patients with intra-aortic balloon pump. In patients with intra-aortic balloon pump, presents a special consideration, whereas VF or systolic arrest are readily identified and the ECG, pulseless electrical activity or an asystole arrest with an active pacemaker may continue to trigger the intra-aortic balloon pump, resulting in arterial waveform falsely suggestive of cardiac ejection and cardiac output. Cardiac arrest is confirmed by the loss of the cardiac component of the intra-aortic balloon pump pressure trace, or by the loss of pulsatility in other pressure waveform, such as the central venous pressure, pulmonary artery, and tidal pulse ox. Pausing the intra-aortic balloon may help to confirm that the patient is in cardiac arrest. In cardiac arrest with the intra-aortic balloon pump, the balloon pump should be set to pressure trigger mode that will allow augmentation of the cardiac massage and also improve the cardiopulmonary resuscitation without interference from the ECG trace. If there is a significant period without massage, triggering should be changed to an internal mode at a rate of 100 beats per minute until cardiac massage is recommended. By here, I got to the end of my presentation. Thank you for listening. This is my reference, is the Society of Thoracic Surgeon expert consensus for the resuscitation of patients who arrest after cardiac surgery.
Thank you, Dr. Hani, for presentation. Any question for Dr. Hani? So we'll take a break for 10 minutes, return back on 1:55. Thank you. Assalamu alaikum. And now the second and final lecture, Pathophysiology and Diagnosis of Infected Endocarditis, presented by Dr. Muhammad Al-Mutlaq. Can you start, Dr. Muhammad, please?
Assalamu alaikum. You hear me now?
Yes.
Voice is clear?
Yes.
Right. My name is Dr. Muhammad Al-Mutlaq. Inshallah, today I will talk about infective endocarditis. So this is the objective I will talk about. Infective endocarditis is the infection of a heart endocardial surface. Classification 224 group: native valve endocarditis, prosthetic valve, intravenous drug abuser, nosocomial. So further classification, acute, if normal heart valves, rapidly destructive, if not treated, usually fatal within 6 weeks, commonly staph. Subacute, often affected damaged heart valve, indolent nature, if not treated, usually fatal by 1 year, commonly Streptococcus viridans. So pathophysiology is turbulent blood flow, disrupt the endocardium, making it sticky. The bacteremia delivered the organism to the endocardial surface, adherence of the organism to endocardial surface, eventually invasion of the valvular leaflet. Epidemiology incidence 1.7 to 6.2 per 100,000 person per year. Male to female 1.7, becoming a disease of elderly. Median age pre-antibiotic was 35, now 58. Due to 2 factors: decline rheumatic heart disease, increasing proportion of the elderly. Prosthetic valve 7 to 25% of cases of infective endocarditis. Early, less than 12 months, late, more than 12 months. 0.94 per 100,000 bioprosthetic valve. Initially, mechanical valve at the greatest risk, the first 3 months. Then the risk same at 5 years. So 1 to 3.1 risk at 1 year. In 5 years, 2 to 5.7%. Risk factors: injection drug use, increasing risk in young, Staph aureus. Intravenous drug abuser, rate 100 to 2,000 per 100,000 person year. Higher among patients with non-valvular heart disease. Structural cardiac abnormality, 75% of patients will have pre-existing structural cardiac abnormality. 10 to 20% have congenital heart disease. Other risk: poor dental hygiene, hemodialysis, diabetic mellitus, HIV. Risk factors of cardiac abnormality: high risk previously infective endocarditis, 2.5 to 9. Aortic valve disease, 12 to 13%. Rheumatic valve disease and prosthetic valve coarctation complex cyanotic congenitals. Moderate risk: mitral valve prolapse, MR thickening leaflet, 5 to 8 times. Mitral stenosis, tricuspid valve, pulmonary stenosis, hypertrophic obstructive cardiomyopathy. Low risk: ASD, CABG. Risk factors, other risk factor: HIV infection. Number of cases of infective endocarditis have reported in patients with HIV infection. It has been suggested that HIV infection is independent risk factor for infective endocarditis in intravenous drug abuser. Rheumatic valve disease, predisposing for young in same countries, 37 to 60 to 76 of cases. Mitral 85, aortic 50%. Degenerative valvular lesion, mitral valve prolapse, and associated mitral regurgitation, 5 to 8 times higher risk. Aortic valve disease, stenosis or regurgitation in patient in 12 to 30. Diagnostic approach: history prior cardiac lesion. Recent source of bacteremia. Symptoms: acute symptom, high-grade fever and chills, shortness of breath, arthralgia, abdominal pain, back pain. In subacute, low-grade fever, anorexia, weight loss, nausea and vomiting, abdominal pain, fatigue. The onset of the symptom is usually 2 weeks or less. from initiating bacteremia. Physical examination, look for the small and large emboli for special attenuation to the conjunctiva, skin, and digitus. Cardiac examination may reveal the sign of a new regurgitation murmur and sign of congestive heart failure. Neurological evaluation may detect evidence of focal neurological impairment. Signs, fever, heart murmur, non-specific signs like petechiae, sublingual or sublingual hemorrhage, clotting, splenomegaly, neurological change. More specific sign, Osler node, Genoa lesion, and Dorothy spots. Other aspect of clinical diagnosis, which valvular, right or left, where would the emboli go? Heart functioning, pump acute valve dysfunction, conduction. Look for evidence of emboli. Bleeding, there is a bleeding, intracranial, elsewhere, myocardial aneurysm. Diagnostic approach, positive blood culture result. A minimum of 3 blood culture should be obtained over the time period based on the severity of the illness. Additional laboratory, non-specific test, this one, elevated ESR, CRB is usually present. Most patients quickly develop pneumochromatic, normochromic, normocytic anemia. The WBC account may be normal or elevated. Additional laboratory, abnormal urine analysis, combination of RBC cast on urine analysis, and low serum complement level may be an indicator for immune-mediating glomerular disease. ECG, new AV or vesicular or bundle branch block. Native valve infective endocarditis, the bacteria was strep, 55%, mostly Streptococcus viridans. Staph, 30%, mostly Staphylococcus aureus. Enterococci, 5 to 10%. Gram-negative bacilli HASIC, 5% fungi. Prostatic valve endocarditis, early from up to 2 months, 1 to 3%. 50% Staphylococci, epidermis more than iris. Enterococci, late more than 12, 2 to 5%. Infective endocarditis in IV drug abuser, Staph aureus, 50 to 60%. This DOC criteria, investigation for DOC University modified previous criteria to include the role echocardiography in the diagnosis and also expanded the category of predisposing heart condition to include intravenous drug user. Modified criteria, definitive endocarditis, myocardium, microorganism via culture or histology in valvular vegetation, embolized vegetation, intracardiac abscess. Histology, evidence of vegetation or intracardiac abscess. Possible infective endocarditis, 2 major, 1 minor, 3 minor, 1 major, and 5 minor. Possible or rejected endocarditis, resolution of illness with 4 days or less with antibiotic. Major criteria, microbiology, typical organism from 2 separate culture or microorganism from resistance positive culture or single blood culture for Coxiella burnetii or titer more than 1 to 800. Endocardial involvement, no change of murmur, regurgitation. The third one, positive echo. TE if prostatic valve complicated or pretest probability of possible endocarditis. Minor criteria, predisposing heart condition or IV drug user, fever more than 38, vascular phenomena, petechiae, sublingual hemorrhage, major arterial emboli, myocardial aneurysm, intracranial or conjunctival hemorrhage, Genoa lesion, immunological phenomena, Roth spot, rheumatic fever, glomerulonephritis, Osler node, microbiological evidence, not meeting major criteria, single blood culture. Culture negative, 50% of culture negative are with the previous antibiotic, HASIC, 2 to 3 week incubation, subculturing. Tend to see subacute with valve destruction. Petechiae, non-specific, often located on the extremities or mucous membrane. Sublingual hemorrhage, non-specific, non-blanching, linear reddish-brown lesion found under the nail. Usually do not extend the entire length of the nail. Osler note, more specific, painful, and erythematous nodule located in bulb of finger and toes. More common in subacute endocarditis. More specific, erythematous blanching macule, non-painful, located in the palm and soles. Complication, for etiology, embolic, local spread of infection, metastatic spread of the infection, formation of immune complex glomerulonephritis and arthritis. Embolic complication occur in up to 40% of patients with infective endocarditis. Predictor of embolization, size of vegetation, left side vegetation, fungal pathogen, Staph aureus, and Strep bovis. Incidence decreased significantly after initiating of effective endocarditis of effective antibiotic. This septic pulmonary emboli and septic retinal embolus. Local spread of the infection, heart failure, extensive valvular damage, paravalvular abscess, 30 to 40%. Most common in aortic, IV drug abuser, bacteria Staph aureus. May extend to adjacent conductions tissue causing arrhythmias, higher rate of embolization and mortality, causing pericarditis, fistulous intracardiac connection. This infection local spread, acute Staph aureus with the perforation of the aortic and of aortic valve and aortic valve vegetation. And the right side, acute Staph aureus infective endocarditis with the mitral valve ring abscess extend to myocardium. Metastatic spread of the infection, metastatic abscess to the kidney, spleen, brain, and soft tissue. Meningitis and encephalitis, vertebral osteomyelitis, septic arthritis. Poor prognostic factor, female, Staph aureus, vegetation size, aortic valve, prostatic valve, elderly, diabetic mellitus, low serum albumin, heart failure, paravalvular abscess, embolic event. Echocardiographic finding, oscillating intracardiac mass on the valve or supporting structure, in the path of regurgitation jet, on the implanting material, or abscess, new partial dehiscent of the prostatic valve, new valvular regurgitation, increased or change in the pre-existing member. This the study showed the patient were studied consecutively with TEE and TTE. TEE is the sensitive 100% for vegetation as compared to 63% with the TTE. Both TTE and TEE is the specific, about 98%. Less than vegetation, less than 5 millimeter can be detected 25%. 69% vegetation between 6 and 10, and 100% vegetation greater than 11 detected by TE were also observed with the TTE. Thank you.
Thank you, Dr. Muhammad. Any question for Dr. Muhammad? So we finished the teaching session for today. Thank you all. The last lecture will be postponed.